I'm Ilona Velarde, and today I'm interviewing Dr. David Dighton, a London and Nicosia-based cardiologist. Welcome, David.
Good, thank you for inviting me.
Our today's subject is a heart screening. My first question would be, what would make a person think of having a heart screen?
Well, the most obvious reason they should have it done is if they're getting breathless, or if they're getting tightness across the chest or chest pain, and if they're just feeling very tired with those symptoms as well. They are the reasons why they perhaps should have one done. Even more important than that is the family history. If somebody has got these symptoms and their father had a heart attack or their mother, that makes a very, very strong reason for having a heart screen. I can tell you though that most people that have heart screens come because they have a friend who's had a heart attack, or somebody they know has died suddenly, and that sometimes makes people come along to have a heart screen. But that isn't actually the best reason. The best reason is if it's in your family. If it's in your family, get screened to see if you have it in the early stages, and we can then help you prevent it getting worse.
So why do you think that it's a good idea?
Well, I think it's become a good idea now because we can easily detect it. Going back 30 or 40 years, we couldn't easily detect it. We had to do all sorts of tests which were invasive, but now we have simple tests like artery scanning and CT scanning, which can show trouble before it arises. We can spot people who have developing artery furring, and we can actually do something to prevent it. There's no point in doing screening if there's no treatment. But in this case, we have fantastic treatments. We can stop the furring, we can put stents into the arteries to open them out, we can stop heart attacks. We've got so many treatments that are worthwhile that it's good to find cases early.
Why specifically heart screening?
Well, we do screen the body in many ways. It's useful for detecting all diseases in the early phases. That's our aim anyway. But the heart is one of the commonest causes of death in the Western world in middle-aged people. So that's actually the reason why we would specifically do heart screening. I could say that a medical examination and screening that leaves the heart out of the screening process is a complete waste of time because it's the commonest cause of death. So unless you've got that covered, it's not worth having a general screen.
So what does a heart screen involve?
Well, all medical examinations start with taking the patient's story. I have to say that this is probably the most important part of any physical examination with the doctor. These days, people are spending less and less time on talking to their patients, unfortunately. But traditionally, and still now, I can prove from my data that the questioning of patients and their answers is absolutely crucial to early diagnosis. So we want to know about all of their symptoms, the tiredness, the breathing problems they might have, the tightness in their chest. We want to know about family history. We want to examine them, but examination doesn't often show anything in early heart disease, not in coronary disease anyway. They may have heart valve problems, so we listen to the heart. We examine their arteries, we do their blood pressure. These simple things. Then we have to go on to more complicated tests like a heart tracing or an ECG. We must include an exercise test, I think, if you are properly going to screen the heart. We have to put people on a treadmill to see what happens to their ECG. Sometimes we become a bit more complicated than that, and we do an echo sounding of the heart and an echo sounding with and without exercise as well. And the other thing we do, which is really crucial, is to scan the arteries. In my clinic, we mainly scan the carotid arteries, the neck arteries first, but we can scan the abdominal arteries and the leg arteries as well. And that's where we would stop on the first stage. The second stage is when we find abnormalities there, we then go on to CT X-ray scans of the heart and maybe even angiograms, but they're not part of routine screening. They're only for people where we have found an abnormality. Blood tests we do, but unfortunately my data shows that blood tests are not much use in early diagnosis. This is a bit of a surprise, I know, but that's the result of over 5,000 case studies. Blood tests are not much use in early diagnosis in individuals.
I'm a bit surprised you said that blood tests are of little use.
Yes, it surprised me really, because I grew up learning that blood cholesterol was very important. But my research in more than 5,000 patients shows that if you look at their arteries and then look at their blood cholesterol and fat levels, there is no relationship between the two. Well, there is a little relationship. For instance, if you take 100 people with third arteries or coronary disease, 60 of them will have 60% of them will have a raised cholesterol, but that makes it a pretty poor test. So we do them as a guide to treatment, but it's not a way of making a diagnosis. The only use of blood cholesterol and blood tests is in population screening, to find out how likely a population is to have heart attacks. There it's important, but in individuals it's not much use.
And what is the use of CT X-ray scan?
Well, that shows the chalk or calcium within the coronary tree, and the more chalk there is, the more likely there is to be an artery narrowing. So coronary artery disease, there's a score, it's called the calcium score, and if it's over 400, then we would expect there to be trouble. If the score is something like 1,000 or 2,000, then it's almost inevitable that the person has got coronary artery disease. Some people use the CT X-ray scan as a routine screen. They can just walk in and have it done. The problem is that it is X-rays, and you can't repeat it every year, or at least I wouldn't advise it. So yes, it's a very valuable test indeed. It's diagnostic, but it involves X-rays, and so we only use it when we find that the other arteries are furred.
And how good is an ECG?
Well, this raises an important question. How good is any test? I mean, if you take the pregnancy test, there's nothing to do with what we're talking about, but a pregnancy test is only wrong 1 in a million times. It will tell you if you are pregnant, with a chance of 1 in a million being wrong, and it will tell that you're not pregnant with a chance of 1 in a million being wrong. So both positively and negatively. Now, if you take an ECG, it may be negative in about 20% of people. So it will look normal when you have heart disease. It is about 80% diagnostic though, but it's only 80% diagnostic, which means it's going to miss 20% of people. So we use it as part of our general screening strategy, but on its own, it's not as good as it needs to be. So we sometimes do exercise tests as well. That increases its diagnostic accuracy by about 5 or 10%. But still, it misses 10 or 15% of people. So not the most accurate test in the world, but it's one of our routines. It was invented a long time ago. We're used to using it. We're used to interpreting it. But it's not as good as it's made out to be. And you shouldn't have a lot of faith in it. Have some faith, but not a lot.
And what about ultrasound artery scan? How good is that?
Well, the research I've done is now over 15 years and about 5,000 patients shows a very close connection between furring in the neck arteries and the coronary arteries. If we take 100 people that actually have coronary artery disease, 99% of them have furring in their neck arteries, which is an interesting result. We're not sure about the other way round. If you have neck artery furring, we think probably only about 20 or 30% of them also have coronary disease, but we have other ways of finding out if they do. It alerts us to the fact that these people with neck artery disease may have coronary disease, so we take their other screening tests very seriously.
What about angiograms?
Pictures taken of the actual heart arteries. We have to put a tube into an artery either from the leg or the arm, and we actually put dye into the X-ray dye into the arteries to show them up. This is not a screening procedure. We only do it when we're fairly sure somebody has coronary artery disease that may need another intervention like a stent. So it's not a screening process. It's one that evaluates the screen that has detected some chance of coronary disease. The levels at which we do this vary internationally. There are a lot of people in some parts of the world that have it when they have any chest pain. They have it anyway. But in the UK, we traditionally have only done it when people have evidence that they have heart disease. So in other words, we don't do it unnecessarily on people. This comes from the history of it. It used to be Not very dangerous, but slightly dangerous. Now it's hardly dangerous at all, but it still does have a risk. And so things have changed, but we don't use it for screening at all.
So the final question is, can screening save lives?
The only evidence that the answer to that is yes comes from experience, which isn't quite good enough from a scientific point of view. But I have seen many people who, if they had have blocked their artery further, they would quite likely have dropped dead, because there are some artery narrowings in the coronary tree where if they really do block, a person would die. And the fact is, our screening has sometimes discovered these. So I'm fairly sure that we do save lives with screening, but the real question, I think, isn't that one. The question for most doctors is the cost. I mean, if we were to screen everybody, I don't think there's a country in the world that could afford it. So at the moment, these types of screening tests really have been limited to people wealthy enough to pay for them, which doesn't make it right, but at least they can define what their risks are and deal with them. Unfortunately, at the moment, it's not for everybody. Even if I say, yes, it does save lives, which I'm sure it does, it's unfortunately not available to everybody, which is really unfortunate, so because of the cost. But yeah, I think the answer is yes, it does save lives.
So, as I understand, you've been doing heart screening for 40 years.
Yes, I started my own clinic in 1973, which is 42 years ago, and I've been looking for heart disease in what you might call normal patients ever since then. I studied invasive tests in cardiology, angiograms, and dealing with people with serious coronary disease. So I decided to start a clinic looking for this disease early on, in other words, heart screening. And the results have been very interesting.
All that remains is to thank you for watching and for Dr. David Dighton explaining us about heart screening. We would like to thank Palm Beach Hotel in Larnaca, Cyprus for allowing us using their facilities. This is Ilona Velarde saying goodbye for now. And please note that we have many other videos that explain about heart symptoms and heart disease. If you would like to have more information about this subject, why not buy or download our Heart Sense book, which is easy to read and contains useful information about the heart and the best diet to eat. In case you would like to read something more technical, you can buy our Eat to Your Heart content book from our websites. And you can also download this very short brochure, Worried About Your Heart, which explains many details about heart problems and which is available in 4 languages: English, Greek, German and Russian. Don't forget to purchase our Heart Sense supplement, which is essential to even the best diet. Soon we will also have Heart Sense tablets, which will be available on our websites. All our products and information are available on our websites, heartsense.com.cy and thecardiaccenteruk.co.uk.